Akula, who is a cardiologist and well recognized for his work on Uddanam Kidney Disease in the Srikakulam District AP. He also has several publications and has presented his abstracts in scientific conferences. He will be presenting on COVID-19 cardiac injury, myocarditis-related inflammation, and thrombosis risk. Please start sharing your screen.
Good morning, good evening, everyone, and thanks for giving me this opportunity. My name is Ravi Akula. I'm a practicing cardiologist, and I've been in practice for almost 17, 18 years, and I practice in New York State, upstate New York. Today, let me share my screen.
You have to click on the green button on that.
Okay, let me see.
Go to full screen.
Yeah.
And choose share screen.
Yeah, that's what I did. Let's see, okay, this one. You see that?
Yeah, it's coming up. Okay.
Sorry for the technical glitch. And today I'll be talking about COVID-19, inflammation, thrombosis, and cardiac injury. And what it has to do with World Thrombosis Day. And when Kumar Gar asked me, and I was thinking it should be appropriate for World Thrombosis Day, and it should be appropriate for the current events that are happening throughout the world. And as we are reeling with this COVID-19 pandemic, and we are learning as we go, because as the good thing is, and we are learning, so much of learning in the last few months. But the bad thing is there's no expert. So we are learning. So today I'm going to share my experiences and the knowledge pertaining to COVID-19, how it affects the heart, and also what is the thrombotic aspect and the complication from that. So as of today, and as we all know that COVID-19 is caused by SARS-CoV-2 virus and the syndrome caused by COVID-19 syndrome. Previously, especially in US, we kind of underestimated the impact of COVID-19 because we've seen in China and towards the eastern countries getting affected, we were hoping that like SARS and MERS, it'll just be limited to those or certain parts of the world. But unfortunately, unlike to the SARS or MERS, it has affected almost all countries or throughout the world. Most of the countries were affected predominantly. So as of yesterday evening, there are more than 36 million patients that are affected and more than 1.1 million deaths. And in US, there are 7.6 million patients and more than 213,000 deaths. So one of the estimation was 1% of the patients that are affected with COVID-19 will die of COVID-19 and complications. So this is the screen from Johns Hopkins website last evening. So this will tell us what's happening, and it's kind of live. They'll be updating almost every day. So this is where we are. And from this, how the 10 predominant countries that were affected by COVID-19, how they're reeling. If you see that India, the numbers are coming down, but it also, you should take into consideration, these are reported cases and reported mortalities. And in the US, in July, towards the end of July, there is improvement, but again, there is stuttering, they're up and down, and hopefully we are looking at the end of the tunnel. So my talk will have three parts. One is inflammation and myocarditis, that means inflammation of the heart, and how that impacts the thrombotic aspect and what the effect of thrombosis in the whole pattern of the COVID-19 syndrome. As we all know, people are dying not because of the viral infection, but the complications from that. The dreaded complication is the inflammation, the cytokine storm, they call it, and also the thrombotic aspects from that. So unlike the other viral syndromes, COVID-19 can affect almost every organ in the body. There's one saying it's going in the scientific community is COVID-19 can affect anything except pregnancy, which might be an exaggeration, but if you look at that, it's true. It's affecting almost every organ. And the way we are practicing is if you see a patient that doesn't present with any typical symptom, think of COVID. So there's a saying here, a duck that makes sound like a duck and walks like a duck, that's a duck. But unfortunately here in COVID-19, we don't know because we don't know what is duck, what is the presentation, how this syndrome is developing. Even today we are learning, but we are much better off 4 months before. We are much better off now because we've learned a lot about COVID-19. So if you go back in the inflammation pathway, if you see here, the COVID-19 virus can affect both coagulation pathway on the left, and on the right side, you see the inflammatory pathways. The inflammatory markers, the interleukins, play a very big role in this inflammatory cascade, the cytokine storm. So usually, the inflammation is a necessary evil. So whatever you're affected with, your body reacts with an inflammation. But anything in excess is bad. So inflammation is a defensive process, but in COVID-19, because of this excessive infection, the inflammation is beyond defensive to the point that it's almost autoimmune. When I use the word, it's because I know that there are some non-medical audiences here and some kids. So to make them understand, to make it easy for them to understand, I'm using some terminology to make them understand. Please take it with a grain of salt. So on the left side, you see the coagulation pathway, and the viral syndrome attacks the body. Both the coagulation system and inflammatory system gets activated. So what is the end result? In the center, you see that the coagulation activation system, the thrombin formation, when it combined with fibrin and the platelets, the clot formation will happen. The clots will be initially, they'll start with microthrombi. In the autopsy studies, they have seen the microthrombi in almost all the organs. So basically, the microthrombi will form, and in the circulatory system, it will go to almost every organ. So what is the importance of that? Microthrombi is kind of nidus. They'll form there, and they can attract more of this inflammation, and then clot formation will propagate. So why is it important? Especially Dr. Vijay Kumar, who is a pulmonologist, and Sudhir. I'm sorry if I'm missing some of the other physicians which I'm not directly acquainted with, because these are the guys who are treating these patients in ICU almost on a regular basis. They'll be seeing all these patients. Why is this important? Because inflammation, what are the complications of that? So patients who can survive the inflammatory storm or the cytokine storm, the outcomes are very good. Very good in the sense they can survive. So as I told, the inflammatory markers. So how do we diagnose that? There are certain markers for inflammation, like indirect markers like C-reactive protein, ferritin, D-dimer. These are the indirect markers of inflammation. So they'll tell us the extent of inflammation, the extent of coagulatory markers, so extent of degradation products. So that's an indirect surrogate marker of the extent of inflammation. So why is it important? So when we are treating the patient, we need to know how to treat the patient. So what is the major treatment? The major treatment is steroids. So it's kind of contradictory because when we are learning in medicine, steroids are immunosuppressive. That means it suppresses the immune system, and so that the defense mechanism will be kind of suppressed. But as we talked before, when the inflammatory system and immune system going array, kind of crazy, we need to have a system of controlling that. So steroids are the mainstay, but the key point here is when to use the steroid. You cannot and you should not be using steroids in asymptomatic or less symptomatic or stable patients. These are reserved for only sicker patients, but it should be done under medical supervision. So why is the inflammatory markers important? Because these inflammatory markers, we talked about C-reactive protein and the D-dimers and all that, that will tell us how bad the inflammation is, and also how the range or the direction of the inflammation. If your patient comes with inflammatory markers and they're stable, so you keep on giving the supportive care. But the inflammation markers are going up, that tells patient is degrading fast. So we need to act fast, and in those circumstances, so steroids are life-saving and predominantly, in fact, one of the study, if you see on the screen, the recovery study from UK, they have done study on 6,000 patients, a huge study on COVID-19 patients, and they've seen the dexamethasone, which is a steroid, it has shown tremendous outcome improvement and also mortality benefit. The similar study they replicated in New York, and they're saying the similar outcomes. But the caveat is you need to be really careful when to use these steroids, and they should be used under strict medical supervision. So we talked about the inflammation and the importance of inflammation in COVID-19 syndrome. So being a cardiologist, I want to talk about what is the importance of this inflammation and the cardiovascular system. I'm going to skip and come back to the other two slides. This is a slide that talks about the inflammation and how COVID-19 affects the circulatory system. If you see that on this screen on the left side, SARS enters and then it starts the inflammatory process, okay? And by inflammation, it affects the T cells and the cytokine storm will form. The cytokine storm will affect the whole body. And the most important for the circulatory system is what it does in the endothelial cells. So endothelial cells are the lining of all the blood vessels. So by affecting that, obviously, if you have any cholesterol buildup and atherosclerotic plaques, the plaques will get unstable. So when the plaques get unstable, they tend to rupture and they can cause heart attacks. So basically here we are talking about this heart attack. When heart attacks happen, the worst thing that's happening now is because of the COVID-19 syndrome, and people are so afraid to go to the doctor, to go to the medical facility for the fact that they might contract virus. They're not taking the medical care that they should be getting that. So in fact, in March, late March and April, when American College of Cardiology studied, there's almost 20 to 25% less cases reported with ST elevation myocardial infarction. What does that mean? That means patient is having a heart attack, but they're not going to the medical facility. So what is the big deal with that? It's not a big deal because heart attacks, most of the patients who survive, they'll be okay. But down the road, what is the complication? When you have a heart attack, a part of the muscle will die. That can weaken the heart muscle, and that can end up in having irregular heart rhythms and congestive heart failure. And then if you come down, the complications with that can affect the heart failure, and that can affect and cause dangerous irregular rhythms. So let's go back to the myocarditis. So what is myocarditis? Myocarditis is inflammation of the myocardium, that is heart muscle. So usually, how is the diagnosis? It is a diagnosis of exclusion. Usually in our practice, we are seeing patients, and the most common consult we get is the patient is admitted, they'll do the test, the muscle enzymes, the heart muscle enzymes, they're elevated, they're in the heart attack range, they'll call us. You go and see there are no EKG changes, no other findings suggest of heart attack, and then probably we'll say it's myocarditis or myopericarditis. Sometimes the coating around the heart, that's called pericardium, that can get inflamed, and these enzymes can be coming into the system. But whatever the cause, the studies has shown the troponin spill, the cardiac enzyme spill into the system, there's a poor outcomes down the road. So you make a diagnosis of myocarditis based on your EKG changes, enzymes, and echocardiogram, and all the routine tests. But usually if you have the biopsy studies or any autopsy studies that has shown the lymphocyte infiltration, most of the common findings in those studies are leukocytes are infiltrated in that. But in COVID-19, the studies have shown they did find in autopsy and biopsy that the virus itself is in the myocardium. So we know the virus directly affecting and attacking the myocardium, and also indirectly by cascading the inflammatory pathway. So both ways the myocardium, the heart muscle is getting affected. So end result, the heart muscle is getting inflamed, resulting in myocarditis. So what's the big deal of a myocarditis? Yeah, most of the time, 90%, 95% of the time, it's not a big deal. You give supportive care, and sometimes the COVID-19, the syndrome is bad, you give steroids, and 95% of the patients will get better with the supportive care, if they survive. However, in 5 to 10% of the cases, if they're really bad, and myocarditis is really severe, that can affect the heart muscle, and that can weaken the heart muscle. That's called cardiomyopathy. When you have cardiomyopathy, what will happen when you have a weak muscle, and when the heart is inflamed in the process of recovery or repair, it can form a scar tissue. When you have a scar tissue, they're more prone for irregular heart rhythms. Wherever there is a scar, wherever you have an injury, you'll repair by a scar tissue formation, which is a normal and a good thing. But in heart, the scar tissue is not good because the scar tissue is a source of irregular heart rhythms. Like a ventricular tachycardia, ventricular fibrillation, they are coming from the scar tissue. And also the scar can weaken the heart muscle. That's not good either. So that can affect in heart failure. So the worst thing with this COVID-19 is most of these patients, like we talked about 90-95%, they're recovering, they're going home well, but down the road, there are reports even like 6 months down the road, the late sequelae, they're seeing dangerous irregular rhythms and also heart failures. So it's very important to take a timely action and treat them appropriately. Just because you're afraid of COVID-19, you're not taking right care, that can affect in long-term consequences like weakened heart muscle, irregular heart rhythms, and heart failure. So as we talked about, we make a diagnosis like a routine EKGs, echocardiograms, and the enzyme spill, the myocardial enzyme spill, is not specific for myocarditis. You can see in any inflammation, you can see that spill, but the other findings on echocardiogram or EKG, and the latest thing is cardiac MRI. Cardiac MRI has shown tremendous promise, but there's a limitation because you tend to overdo with cardiac MRI. So here in the screen, you see that there's on the right side, there's a cardiac MRI. If you see that, you can see that inflammation. See that part, that is suggestive of inflammation there, especially in the right situation. If you have a patient who has a virus and inflammatory pathway going on, and you see the patient with a troponin spill, that means muscle enzyme, cardiac enzyme spill, and you see that these findings that is suggestive of myocarditis. So there's a latest article in JAMA last month. They're talking about these studies, almost 60 out of 100 patients have seen active inflammation. These are the patients that has undergone cardiac MRI, and they has reported. It's good and bad in the sense, good, you can make a diagnosis of myocarditis early, but the bad thing is, it's kind of alarming situation. As we talked before, 90 to 95% of the patients, when you have heart muscle affected, they'll recover with a good supportive care and in a timely manner. But in the 5 to 10%, you can have the prolonged complications. But with this report, there are a lot of what you call domino effect. What is the domino effect? Now, the American Society of Pediatrics has recommended these competitive athletes. That means these patients, in fact, the 3 of the 6 patients, they have active myocarditis, and they said they cannot take part in active competitive sports for almost 6 months. Can you imagine an active competitive athlete sitting in an active season for 6 months? That's a tremendous effect in their careers. So what is the next thing? We don't know, because we're learning as we go. But right now, the recommendations are, if you have an active inflammation anywhere in the body, you should be careful, especially in the heart, because in inflamed heart, and you put a load by the competitive athletes or tremendous impact, that can even worsen the heart muscle, making the heart more vulnerable for irregular heart rhythms and also heart failure. So what are the other impact of inflammation?
Ravi garu, you have 1 minute, Andy.
Sure. So I'll jump. And the inflammation can cause thrombosis, and also it can cause, this can affect throughout the body. This is a CT scan of the lung that is showing the emboli, that means clots in the lung. And I'll skip to that, go to the thrombosis part of the COVID in the last minute, because as we saw before, the COVID-19 can activate the coagulation pathway, inflammatory pathway, and the thrombotic pathway. By activating the thrombosis, it can initially it affects the endothelium, and then it starts the cascade of the thrombosis. Usually because thrombosis is happening throughout the body every day. The clots are forming, they're being autolyzed almost every day. But there's a different system. Usually there's antithrombin system, tissue factor pathway, and these pathways are deranged in this viral syndrome. So the patients are more prone for thrombin and the clot formation. Usually the Vichos triad, we know that when you have stasis, endothelial dysfunction, and hypercoagulability. So when you have all these 3 systems, you tend to form a clot and propagation of the clot. In COVID-19, you have all 3 of them. When you have hypoxia, that means low oxygen level because of the COVID-19, you tend to have hypercoagulable state. And then the virus itself affects the inner lining endothelium, and the stasis because of that is to start the thrombotic process. And with this endothelial dysfunction and this cascade, they tend to form the clot formation. And as we discussed before, the microthrombi, they're spread throughout the body, and almost every organ will be affected, and they form clots. And this is the pulmonary embolus. If you see here, see the huge, they call saddle embolus. That means it's affecting the huge thrombus, affecting the both sides. On right here, you see that in the deep veins, you have that these are the clots. And this is, every system has their own system. Now, empiric anticoagulation, when you have a patient at risk, we are starting and empirically treating with blood thinners. These are the different ways of diagnosing and making echo. Ultrasound is the mainstay. Even echocardiogram during this process has found a new niche in making a diagnosis. How do you treat that coagulation or thrombosis process? By blood thinners. But the latest one, the COVID-19, FDA has approved Impella and ECMO. Impella is when the heart gets affected, heart gets so weak, it cannot pump. Impella is a temporizing system where it does offload. That means it does pumping for the heart. So weak heart doesn't have to work at that heart. ECMO is a kind of artificial lung. It does breathing system when the